It is now June 16, 2022. We're at the Deuk Spine Institute Surgery Center, Viera. We've already completed one procedure this morning, which we did not broadcast. Now we have 4 more procedures. The 3 of them today will be cervical Deuk laser disc repair, where we're repairing herniated discs in the cervical spine for people suffering with symptoms of herniated disc, whether they're neck pain, pain down into the shoulders and arm, headaches from the herniated disc. This first patient is having C3-4, 4-5, 5-6 Deuk laser disc repair performed. So you could see the MRI scan down on your screen in the bottom corner. There's some large herniations. We'll get started. Our patient is intubated under general endotracheal anesthesia. They are asleep. They will stay asleep for the whole surgery. All right. If you have any questions during the surgery, feel free to ask us. Otherwise, we're going to get started. Again, our patient is completely asleep for the cervical case. Shot. All right, 2, 3, 4, 5, 6. That's pretty good. I could go a little bit more north. Shot. AP. Get those out of the way, please. You're right in the way.
Watch your arms over there.
Shot. That's it? Okay, good. Let's go back to a lateral. So on the AP view, it looks good. On the lateral view, we're lower than I want to be, so I want to move north just a smidgen to get started. Shot. 2, 3, 4, 5. So I'm going to move my fingers north. Shot. Yeah, I want to go a little further north. North, by the way, in case you don't know, means towards the patient's head. Towards their head. Shot. That looks good. Shot. All right. Shot. Give me an AP. Quick AP. Just a quickie. That looks good. Back to a lateral. So I'm in the middle, a little bit off to her right side. I just need my lateral view and we're ready to get into the disc. Now, this patient happens to be allergic to dye. Shot. The kind of dye that is used in X-ray machines. Shot. So we will not be using any of that X-ray dye today. Shot. Perfect. Shot. AP. One more quick AP. I think I'm right where I want to be. Just want to verify on the AP. Perfect. Lateral. So we're in the middle of the spine where we want to be when we enter the front of the disc. Should be close to the middle. And by the time we access the disc to the back, we're going to be going to side. Shot. All right. So do have a little bit of bone spur here. Nothing I can't handle. Shot. Now, we use 2 types of dye. One is a blue dye. I need the yeah, I could do that. The first type is a blue dye which stains the herniated nucleus pulposus and helps guide the surgery. The second type of dye is an iodine-based dye that's used for X-rays. That's the one that this patient's allergic to, so we're not going to give any of that. You won't see the discogram material. Shot. Just want to make sure that my needle is in good position. And advance it a little bit. Shot. That should be good. Remember, you won't see the dye on the X-ray because we're not using it today. Really for 2 reasons. One, she's allergic to it. And the other reason is because there's a national Beck shortage on it. So we don't have enough, and it's not absolutely necessary for this procedure. So that's why we're not using it. All right, we've lost about a drop of blood so far. And I've just numbed up the skin with a little lidocaine, marcaine, epinephrine. And we're going to make our incision. Now the incision is going to be on her left side of her neck because her right side is the worst side. I always go to the opposite side of the worst arm symptoms. Okay? Her chin is here. Her chest is here. So this is her neck. And we're going to make a small 4mm incision with a number 11 scalpel. That way we can put our endoscopic tubular retractor in. So this is not a percutaneous surgery. Some people do percutaneous spine surgery. This is not percutaneous because percutaneous means it's done through a needle. And this surgery is done through a tubular retractor, surgical retractor. Just like every other open type of surgery, it's just an open endoscopic surgery. 2, 3, 4, 5. So we started at the middle disc that we're treating today, 4, 5. We'll be going up a disc and down a disc. We're doing 3 discs total. 3, 4, 4, 5, 5, 6, and again we're starting at the middle disc, 4, 5. I like to do that because then that gives me the starting reference point. Shot. Which means that I can see the guide wire went in just a little bit. It's fine where it is, but I don't want it going in any further. So I'm just going to keep an eye on it. We use the X-ray machine for 2 purposes. Localization, because localization means identifying the disc that we're treating. We're localizing where we are, what we're working on. And then navigation. Navigation means going from one place to another in the body. So the X-ray machine is used for navigation and localization. Our incision I made is about 5mm shot. Yep. So I'm going to pull the guide wire back a little bit just to be safe. I'm going to shot. I'm going to push the dilator in. And I think we're good. I want to get an AP view. You can see the whole surgery will be done through this 5mm incision. So normally we do a 4mm incision, but today I was a little generous by a millimeter. So 25% larger skin incision. Can you imagine, folks? Have you ever seen surgery done on a spine with this small incision? I could tell you 99% of neurosurgeons and orthopedic spine surgeons have never seen this type of surgery done because it's a new type of surgery. It was developed in Asia, shot over in Korea, South Korea. And that's who I learned how to do this from, the beginning part at least, and then the rest of it I developed myself. Mallet, shot, that's it. All right, so we're going into the 4-5 disc, C4-5. We're going to be fixing a C4-5 disc herniation. Now the dilator is passing through the jelly part of the disc right now, and right in the back of the disc where the herniation is at this point. We're going to bring our tubular retractor. So you can put this down here. Okay. Can you all see this?
Yes.
This is a 4mm wide tube. The whole surgery will be done through this 4mm wide tube. This is called the Deuk laser disc repair. It was literally pioneered and developed at Deuk Spine Institute 16 years ago. And I've been doing these surgeries for 16 years. We've done around 600 cervical and around 900 lumbar, and we've completed about 19 thoracics. So yes, we can do this on the thoracic spine as well. All right, I have to advance the tube down to the back of the disc so I could do the surgery. Again, we're going to use X-ray guidance. I want to watch the tip of that dilator and make sure it's not advancing. Shot. As a matter of fact, I'm probably going to pull it back just a little bit. Shot. And if you're looking at my gloves, you may notice that they're dark. There's something dark underneath, and that's worth talking about. Those are radiation gloves. Basically, they have lead in them, and they protect my hand from the radiation from the X-ray machine. Now, when you do this kind of stuff every day, it's this side down, okay? Not this side. When you do this procedure all the time, you get a lot of radiation as a surgeon because my hands are in the field. Now the patient, on the other hand, is going to get a little bit of radiation, but typically they don't have more than one surgery, so they're not going to get daily radiation like I do. You notice how the dilator is moving forward, right? I've got to stop it from going any further. I'm going to back it up again. Shot. It's a little too much. Shot. All right. Let's try that. Is Chet around? I need Chet. No, I'm talking to Henry.
I can call.
You have him? Where is he? Ask him to come to the OR, please, if he's available. All right, we are pretty much at the back of the disc. Now, I could try to get a little bit further because the herniations do go into the epidural space. Shot. And I want to... Thanks. I'm just going to advance this 1 more millimeter. Shot. That is good, right there. All right, so that's as good as it gets. We're literally docked with the tip of this tube at the back of the disc in the annular tear. Now I have 2 goals here, folks. What are they? Number 1, remove the herniated disc that's pushing on the spinal cord and nerve roots. So decompression. And number 2, annular debridement. And annular debridement means I'm cleaning the tear in the wall of the disc, in the back there, the back wall of the disc, the tear in the back wall of the disc, where the herniation came out of. And that's what other surgeons don't do. They don't know about that. They don't do it. But we've been doing it at Deuk Spine for 16 years. It's called the Deuk laser disc repair. It's even been peer-reviewed and published in Surgical Neurology International and indexed in the National Library of Medicine. What does all that mean? It means it's been vetted. It means the procedure has been vetted and approved by my peers and published with good results. And that's been for 12 years now. Oh, sorry, 10 years. All right, let's see. All right, now we're at the bottom here. There's the herniation right there. See how beautiful of a procedure this is? Now, I didn't develop the first transdiscal endoscopic anterior cervical surgery. Like I said, the Koreans did. South Koreans specifically, not the Kim Jong-il guys. And they did this just to do what's called a decompressive discectomy. They never do an annular debridement. But the annular debridement is honestly more important than the decompressive discectomy usually. The reason is that the disc will not heal without the annular debridement. The disc cannot repair itself without the annular debridement. So we have too much targeting red, guys. Where does all the targeting red come from? Why? It's just so red in here. Let's turn the targeting beam down. Anyway, what you're seeing here is at 12 o'clock is sort of the right side of the disc. What's wrong?
Well, you're saying we can do it.
Oh, okay. Turn it down, please. You guys should be checking that before you come in. Before I come in. No, that's fine. Thank you. Yeah. How did the targeting beam get turned up? Because we never use it that high. Does it default when you turn the machine on to that?
Yes, sir.
Really? So you have to turn it down every time?
Yes.
Huh. That doesn't make sense. Maybe you can talk to the rep and find out how to set the default lower. It's kind of inconvenient to do it the other way. All right, so this is the herniation I'm working on right here. You could see the end plates left and right. That's the C4 and C5 end plate. Notice how the herniation here is stuck. It's really not just coming out. So the laser is absolutely necessary to remove it. It's scarred right there. It's all scar tissue. This is scarred in from chronic inflammation within the annular tear in the back of the disc. Remember, herniations are very inflammatory to the body. The body hates herniated nucleus. It's Chad, hi. Can you give us a minute and just put us on, actually, let's show the audience why herniated discs do cause pain. Neck pain, arm pain, headaches, through inflammation. Let's show the audience our video.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
We're still working at C4-5, and we're going to show you what the Deuk laser disc repair does, okay? Hold on. Why don't you show them the video of the Deuk laser disc repair?
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay. I want an answer today. Welcome back. We're just zapping away at the herniation here at C4-5. Everything's going well. You can see the laser fiber is the glass tube there. This is all scarred. This has been here, this herniation has been here for years. Right back here, right up against the spinal cord. And this is all scar tissue and calcification within the herniation from inflammation. So the herniated nucleus causes a massive inflammatory response. That's why people get neck pain in their neck from a herniated disc. That's why they get headaches. That's why they get arm pain. Arm pain, headaches, neck pain are all from the annular tear. They're not from the herniation. The herniation causes inflammation in the annular tear. But at Deuk Spine Institute, we're the ones who discovered back in 2006, that's when I discovered that it was an inflammatory process, not a compression issue. Unfortunately, the rest of the world still thinks herniated disc cause symptoms through compression, pressure. But it's not pressure, it's irritation, chemical irritation. And getting the word out is very difficult to do. Those are fibers of the posterior longitudinal ligament you're seeing there, the white fibers, right there. And this is all still part of the herniation that I'm working on. Luis, how can you help Chet?
Well, I can search also for parts. The problem with eBay is just the warranty.
I don't care.
Okay.
We cannot, we have one compressor.
Yeah.
That goes down and
We're done.
we're done. And Chet doesn't seem to get that. Okay? So I need a backup plan to Chet. I mean, you understand it. He doesn't. There's a herniation right there. A more recent one, by the way. This one doesn't look as scarred up. Wow. Having trouble getting out the end there. So just so you understand, this stuff is normal. This is not normal. This is where the herniation was sitting, and most of it's gone. What's left is a little rind, like an orange peel, the peel of the orange. Imagine eating the fruit out and just leaving the outside of the peel. That's what I'm doing, because we don't want to go through there and end up in the spinal cord. So we want to just get the source of the inflammation and allow this disc to heal. When the disc heals, it will scar like this as well, but it won't be as thick, because the thick scar is really just from years and years of inflammation caused by the herniated disc irritating the annulus. All right, our next surgery will also be a cervical Deuk laser disc repair, so similar to what we're seeing today. This patient's having 3 discs repaired. The next one will have, I think 2, right?
Yes, 2.
Yeah. So we have a 3-level, a 2-level, and a 2-level today. So you're going to get your fill of cervical Deuk laser disc repair. Now, another thing I want to say is that this disc is degenerated. You can see it on the MRI. So we have a lot of people who say, oh, but the laser won't work for degenerated discs, right? No, it works for degenerated discs, and it works for herniated discs. It works for all types of disc problems, whether it's a bulging disc, a herniated disc, a degenerated disc. And the reason is because the pathophysiology of all those conditions is identical. It's the same.
We have a couple of questions.
Yeah, I'll take them.
All right. The first question comes from Sujoy on YouTube.
Hi there.
And they said, "Sir, I am a pain fellow interested in endoscopic spine surgery.
That's great.
Can you please elaborate to me on how do you decide your needle navigation, in parentheses, C-arm conformation?"
Well, I mean, we're showing it to you, so you can see all the details of how we do it. I'm not sure exactly what you want to know. And by the way, we do have this procedure published, so you can go to PubMed and you can read the paper that I published in 2012 and 2013. And it goes through the technique in great detail. I'm glad you're here watching, and I appreciate your question. But I mean, I showed exactly how we navigate using the fluoro machine and the spine, lateral and AP views. But this really is not a procedure for pain management doctors to do. And I don't know what country you're in, but in the United States it would be completely unacceptable. This is a surgical procedure for surgeons. There's a herniation right there out of the foramen. I know pain management doctors want to expand their scope of practice and do more surgeries, but Unfortunately, you know, surgery should be done by surgeons who are trained in surgery. The reason is, number one, the anatomy, the surgical anatomy, most pain management doctors don't know. And number two, you guys don't know how to handle the complications of this type of procedure. So to be able to identify a complication and manage it is very, very surgeon-oriented. I hope you can respect my opinion. That said, I have no problem sharing the technique and how we do it with you. That's why we broadcast, so you can learn.
All right, and the next question comes from Red Rover 809 on YouTube.
Uh-huh.
And they asked, how long does it usually take the disc to heal post-op?
So great question, Brett. How long does it usually take the disc to heal post-op? The answer is a year. It will take this disc a full year to heal. Discs heal very slowly because they don't have, there's another herniation from the foramen on her right side. Disc heals slowly because they don't have a good blood supply. You notice there's no bleeding? The reason there's no bleeding isn't because isn't because the laser is coagulating all the blood vessels. The reason there's no bleeding is because there's no blood vessels in a disc, typically. Yeah, thanks. The blood vessels in a disc are only found in the back of the disc, where the outer annulus is. So we're just now getting into the outer annulus now. All right, that's looking pretty good. Let's turn down the light intensity a little bit. It's a little bit too bright.
Yes, yes.
One click maybe.
No, the top one.
It's a bit overexposed. One more. Did it go down?
Keep going.
Yeah, that's good right there. Let's leave it there. Thank you. So right here, what we're seeing, that's the foramen, the right foramen at C4-5. And you can see the annular tear. I've debrided it. The nerve root is right there, literally right there, coming off the spinal cord. I'm going to go back the other direction and work the other way. And, you know, there was a question earlier from a fellow in interventional pain management that I answered. But the other thing that I want to make sure everybody understands, this is not the kind of surgery you can watch online and go and perform on a human being. You'll kill them. You will literally kill that person. I am a highly, highly trained neurosurgeon, and I make these surgeries look easy, but they are not easy to do. And they're about as easy as walking through a field of landmines, okay? And there's so many potential for complications that I know exactly how to avoid them. I have personally done over 1,000 ACDF surgeries in the neck. That's exactly the same approach I use for this surgery. Anterior cervical discectomy and fusion. This is the right foramen. It's completely clean and devoid of any herniation at this point. There's a little bit here, superficial, more deep in the disc, but kind of superficial to our position. Long story short, what I'm saying to you is the only reason I'm able to do this surgery is because of my vast, vast experience as a spine surgeon doing surgical approaches to the anterior neck and spine. That's not something a pain management doctor ever does. By the way, that's a great picture of the nerve root. You see it right there? That is the C4 nerve root. You can see the axilla of the root right here. This is a good one, Henry, to keep.
Yep.
And title like a segment nerve root, C4 nerve root. Right C4 nerve root. The shoulder of the root is up there, the axilla of the root is down there, that's the foramen. So I would love to keep this for educational talks and stuff. Flip it.
Copy that.
Flip it. Flip it. Yeah, don't let it go down too far. All right, so this looks good. Those are fibers of the posterior longitudinal ligament at the back of the disc. I don't see any more herniation here, and nothing that needs to be treated. So I don't believe in gilding the lily. There's a little bit right here. And gilding the lily means, you know, going beyond what you need to have the best therapeutic result. So what I'm saying is, at some point you're done, and you need to stop. And that point is almost now, and it takes a lot of experience to figure that out, where that point is. This is just a little bit more of the herniation I want to get. You can see the dura right there. That's kind of lateral on the, those are the fibers of the posterior ligament. And just beyond that is the epidural space. So pretty much done here. I don't see any more compression. Let me just take one more peek that way. Any questions?
Yes, we have a question from John on YouTube. And they asked, can this procedure be used in an emergency situation where an injury has caused the annulus fibrosus to rupture, resulting in the nucleus pulposus putting pressure on the spinal nerve, causing paralysis?
Yes, this procedure can definitely be used for those situations, okay? Great question. We're done with this level. So this procedure can be used in an emergency situation. We do that type of surgery all the time at Deuk Spine. Not necessarily paralyzed people, because those kind of people end up going to the hospital. We are not in a hospital here. We're in a surgery center at Deuk Spine Institute in Orlando, Florida. We avoid the hospital because the truth is these surgeries don't need to be done in the hospital, okay? They're outpatient. They're very safe to be done outpatient. I've been doing them 16 years outpatient. What outpatient means is not in the hospital, but in a surgery center with operating rooms and pre-op and post-op, and basically like a mini hospital focused on surgery. That's pretty much what we are, but just focused on surgery with the spine. We don't do any other types of surgery, just spine. Pain management and spine surgery. So to answer your question, most patients that end up having an emergency, they go to the hospital. And the ambulances take them to the hospital. They don't take them here. So theoretically, if this procedure was being done at the hospital, let's go, Jordan, then yes, they could be done at the hospital by a neurosurgeon at the hospital. Unfortunately, right now, the reality is I'm the only neurosurgeon in the United States doing this surgery, because the other neurosurgeons haven't been trained, and they're more interested in doing old style surgeries like fusions, and it's very complicated, but it's really a cultural problem in every country, but especially the United States. And what I mean by that is, yep, you can see we actually got all the way down into the herniation there. That's why we're seeing the dura. All right, good. Shot. So now we're going to come out, and I'm going to take the tube out. I'm going to leave the dilator in. Shot. Shot. So you got to monitor what you're doing the entire time with the x-ray machine. Shot. So the good news is that what I found there, I need the, come on. Will you tell him the right thing to have in his hand? Shot. Are you pulsing?
Yes, sir.
The good news is what I found in the back of the disc was not bone spur. It was just calcified herniation and scar tissue. So that's good. Now I'm going to bring the tube out completely. I'm going to leave the dilator in. All right. Luis, why don't you come help out? Shot. All right. So I'm applying pressure. Shot. Shot? You're using pulse, you said, right? Yes. Good. All right, so we're going to start planning the next disc. I think we're a bit overexposed on the x-ray. I don't know why we're always so overexposed, Jordan. Can you just fix that, please, for me? Okay, I see. So you wanted me to see C5-6. Yeah, that's why. All right, we're going to go to 5-6. I think you overcompensated. Let's go back, maybe split the difference between where you are now and where you were before on the... That's good. That's good. All right, good. So overexposed is like a picture you're taking when there's too much white light. You can't actually see what you're taking a picture of. It just gets whited out. And the same thing happens with x-ray machines. So Jordan is actually adjusting the intensity, right? And it's basically computer programming, processing of the image. All right, we're going to go for the lower disc, everybody. The lower disc, the next one down. 2, 3, 4, 5, 6, number 5, 6. So we need some inline traction from the anesthesiologist. We may need a little shoulder pull. Jordan, I need you to move down just south a little bit just to penetrate the shoulder a little better. All right, let me know when we got shoulder pull. That's good. That's good. I like the position of the fluoro. All right, so I'm going to come out of this disc space, and I'm going to go down to the next one. Shot? Can you give me a little more visibility on that disc, please? Some bone spurs here. Shot? Feel I'm right on the lip. Shot? And this is the part that really needs a neurosurgeon, not a pain management doctor, okay? Shot? AP? This is not the type of thing that a pain management doctor can do. Period. All right, so we're in the middle relatively, and I need to move down a little bit more to the next disc. Sean, I'm actually feeling the spine as I'm moving, and Sean, yeah. All right, let's get an AP, see where we are. Everybody stay where you are, nobody move. Quick shot, Jordan, it's not a setup shot. Yep, lateral. Looks good. So I'm going to go back to a lateral. You can see the esophagus is deflected. I need a little better penetration down there. Good. That's it. I feel it. It feels good. Yep. Let's just check the AP one more time. Give me a good AP. Everyone stay where you are. Yeah, this is 100% not a pain management doctor procedure. I'm sorry. If you want to, huh? This requires literally an operation with a lot of team members, a lot of specialized equipment, specialized training. Not to say that pain management doctors don't have that, they do. But this is truly a surgical procedure. Shot? I would not let a pain management doctor do this on me. Shot? I need to see that disc better. 2, 3, 4, 5, 6. We need about 30 seconds more. Shot. Let's get an AP. Move that back, please. Take this. Give me a coker. Yeah, Oscar, you're not quite ready yet for the prime time for this procedure. Maybe a single level, something a little bit easier to do. That looks perfect. Let's go back to a lateral. It's okay. It takes time. So you can see the entire 3-disc surgery will be done through basically a 5mm incision today. Again, I'm not forcing this. This takes, honestly, what looks like I'm just hammering this thing in, but I'm actually feeling it with every single blow of the hammer. And it's the kind of feel that literally only a good surgeon will have. You can actually feel this moving through the disc. And I could feel the resistance, and it's a measured amount of resistance that I'm used to after doing, like I said, 600 cervical Deuk laser disc repair patient surgeries, but then each one is 2.5 discs. So total of about 1,200 discs that I've passed through. Does that make sense? So that kind of experience just comes with a lot of surgery, a lot of before I even started doing these, I did all those ACDF surgeries. So I learned the anatomy very, very well. We don't need the guide wire, do we?
No, it's just for this one. You don't want to...
No, we're not going to do a discogram. No. We're right where we need to be, and I'm happy about it. Everyone can kind of relax at this point. Are you still giving inline? No. Nah. I'll let you know if I need it. So tube is going down over the dilator. Great questions today. I appreciate the audience asking. By the way, in case you haven't noticed, I'm not a person who will tell you what you want to hear. I'll tell you the truth. And it makes me unpopular with certain people, but that's okay. It's a guiding principle of my life is to be honest. I guess I could be nicer, but that just takes too much effort. Besides, I want to be appreciated for my results of my work, not my niceness. There's always going to be nicer people than me in life. So, but nobody will have better results than I do with surgery and pain management. All right, I do need you to give me some distraction, just inline traction. I need shoulder pull. Who's got that? And give me a count. 1, 2, 3. Shot. All right, looks better. Stay with me, everybody. Shot. Shot. Yeah, I need to pull the dilator back. Relax for a moment. Just relax. Any questions from our audience?
Yes, we have a question from Reiko Pilot on YouTube.
Ah, all right. We need to get this back. Can you help me? Go ahead with the question. We're going to be pulling the dilator back. We're at C5-6. C5-6 currently.
And his question was, does an MRI image show enough information for a doctor to determine whether a disc herniation is chronic or an acute/recent event?
Great question, Reiko Pilot. Thanks for asking. So to answer your, a little inline. Maybe that'll help get it out. You feeling it? I don't need it all the way out, just a little bit. No, the tube moved. No, go ahead. So the MRI does not give you enough information to tell if a disc herniation is acute or chronic, but it's a complicated question. Let me see. Yeah. I need, let's do that. What about the grabber? Will the grabber, the thing work?
The extractor?
Yeah.
The extractor? I mean, can you bring an extractor, please? Yeah.
Mhm.
Let me try one more time because the extractor is...
So here's what I can tell you. Reiko Pilot, the most important thing to take into consideration, you got it?
Yeah.
Don't open it, we got it. Don't open it, we got it. Shot? All right, good. The most important thing, leave it in there. The most important thing to understand, Reiko Pilot, is that herniated discs don't happen at one time. You don't just get a herniation like you get married, all right? Herniated discs are like having teenagers. You're going to have to live with them for years and they keep causing problems. So the herniated disc happens more than once. It herniates and then it herniates again and again and again and again and again over years. I've seen some people's herniation 40 times, okay, 40 little pieces of herniation. And every time they herniate, they get pain and symptoms flare up over 20 years, you know? So when you ask, is a herniation old or new, there's always going to be newer parts and there's going to be older parts. Was that you? Shot? I don't know if that makes sense. Now, can I tell on an MRI if there are newer parts in that old herniation? Yes, sometimes it's hard to tell, but the gray stuff in a herniation, when it's gray, is typically newer. And the black stuff is typically older with calcium.
Can you check
On a T2 weighted image. Shot? All right, put it back a little bit. This disc is so, that's a little bit. This disc is so collapsed that that's too much. Bring it back just a little bit. Shot? That's good. Yeah, perfect. So we're having to just slowly progress through the disc, because what's happening is the outer tube is grabbing the inner dilator, and as I move the outer tube forward towards the spinal cord, the inner tube is moving with it. The dilator is moving with it. And we don't want that, because that's going to end up pushing the dilator in too far. Hold this. So I'm just advancing things slowly and carefully. Shot? Oh, it's amazing. Shot? Shot? All right. Traction. We need to get a little further and we'll be ready to go. Shot? Almost there. Perfect. That should be good. Oh, nice job, everybody. Nice job. Okay. Took a little more effort, but you see what I had to do is not just standard, right? I had to manipulate things a little bit. I had to change what I do just a little bit to accommodate this patient's disc. And that's something that takes years of experience to do. So I don't want people thinking this is a pain management procedure that can just, you go to a weekend course and you're good. Did I answer the question entirely? I don't know if Rayco Pilot is satisfied with that answer, but you know, like I said, most disc herniations are herniations, plural, and they occur over years, and there's going to be older parts and newer parts. I need the scope on, please, guys.
Please, lights off, please. Thank you.
Thanks. I need that screen closer to me. It's so far away. Yeah, but tilt it down a little bit. Thanks. That's good. All right. My anesthesiologist tells me a patient's doing well. Some of you who watch our surgeries often may notice, lasers on,
Ready?
that this surgery is done with the patient asleep, as opposed to the lower backs and the thoracics where the patient is awake for the first part. Now, what I mean by asleep is complete general endotracheal anesthesia. Tube down the throat. We don't have the blue dye here. Okay? There's a piece of herniation right there. It's calcified with a gold color. It's very scarred up and calcified. So I'm going to float it out. Any other questions?
No current questions, but Rayco Pilot commented back, yes.
All right, good. Let's go ahead and run our video one more time on the Deuk laser disc repair and how it works. And then we'll show our audience the alternative surgery for this patient, what they would be facing if they chose to have a fusion instead. And so we have a comparison video that will show you the difference between this new technology, the Deuk laser disc repair, endoscopic surgery, versus the old technology, which is basically fusion.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own and can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. In a moment, we're going to show you our comparison video of DLDR, Deuk laser disc repair, endoscopic surgery that you're watching, versus a fusion, which would be the alternative treatment. But before we do that, I want to just address Reiko Pilot's question one more time. Reiko, you see all the gold color down here? That's calcium. When the laser hits calcium deposits, then it turns it gold. Now, these are not supposed to be there. It's abnormal. You will not normally find this in the back of a disc. It's only here because of chronic inflammation. And the only reason there's chronic inflammation is because of the chronic herniation. If there wasn't a herniation, there wouldn't be the inflammation, there wouldn't be this calcium deposits or osteophytes basically forming inside the back of the disc, okay? So the fact that there's calcium here tells me this is an old herniation. Now that right there is new. See that? The fluffy stuff, that fluffy stuff is a newer type of herniation, like usually within the last year. But the calcified stuff is old, like years old, many years. So I can already tell because there's a mixed bag of herniated stuff and scar tissue. This disc herniation has been around for many, many years. And she's probably herniated over and over and over again over the years. That's why there's a mixture of different herniation fragments of different ages. You know, it's kind of like a population of people. You see people of different ages, right? You got young babies, you got young adolescents and kids, and you got older people, teenagers, you got young adults. So you have a mixture of different ages of people in a population. And that's what we're seeing here is a population of herniations. And that's how it is, honestly, for most people. I've never seen a herniation that it was just one piece and nothing more. It's always multiple herniations. And as I said, it could be anywhere from 2 to probably 50 or 60, depending on how many episodes that person had. And the episodes occur with lifting and bending. Basically, any kind of pressure on the disc will push out more jelly through the tear. It's actually pretty simple to understand, you know. It doesn't take a neurosurgeon to understand the concepts. The goal of these surgeries, by the way, and broadcasting them, is to educate the general public and doctors, treaters, providers, that there is an alternative to what we all hear about, which are spinal fusions and artificial discs. There's a better surgery, better, in every count, better. And people need to know that, so they know the truth, so they don't believe that they just have fusion, or they don't believe they just have to live with it. You don't. We can fix it. So, and it can be fixed, you know, through different treatment techniques, but one of them is the laser endoscopic that we do here at Deuk Spine. All right. A lot of old herniation here, lots. Gonna flip it, come back the other way. Any other questions?
Yes, we have 2 extra questions from Facebook.
Sure. Let's answer those, and then let's run the comparison of DLDR versus fusion.
All right. First question comes from Becky on Facebook.
Hi, Becky.
And
Welcome to our live stream.
And she asks, after the healing process, how likely is that a person may have another/more herniations in the discs that have previously been a problem and had the Deuk laser disc repair?
Hey, great question, Becky. We get asked that a lot. The answer is About 1%, so 1 in 100 patients with this surgery will re-herniate. And in my experience, oh, there's a piece of herniation right there. That's fine. In my experience, it's always related to them not following instructions. So the instructions are no heavy lifting, and specifically no lifting more than 25 pounds for the first 6 weeks after surgery. Then it goes to 40 pounds for the rest of the year. So on the 1 year anniversary, the disc is completely healed. But until then, I always recommend a light lifting schedule. So 25 the first 6 weeks, 40 pounds after that. Then the other thing for these cervicals is contact sports, like jiu-jitsu, gymnastics, football, rugby, you name it. If you get your neck torqued after surgery before the disc is healed, then you can re-rupture it. And what I always hear a lot, about half the patients that have re-herniated, it happens at night while they're sleeping. So they wake up and they have another herniation. And the way we combat that, or our countermeasure, is have the patient wear a collar, a soft collar, and not a soft, but like a plastic and soft material collar, for 6 weeks to 8 weeks after the surgery, depending on the condition of their discs. So we have strategies in place to prevent reherniation, but the number is about 1% of our patients will reherniate. And we have to redo the surgery. So it definitely happens. But I will tell you this, the reoperation rate for fusions is much higher. The reoperation rate for other spine surgeries is always higher. So of all the spine surgeries available in the world, this surgery has the lowest reoperation rate of 1%. We've had 0 complications in 16 years of doing this surgery. Not a single complication with the procedure at all. So the surgery doesn't cause, we haven't had any injuries to blood vessels or nerve damage or spinal fluid leaks or any infections. It's a very safe procedure to do. So the effectiveness, 98% elimination of neck pain and arm pain and headaches. There's no surgery that's more effective or even comes close. The complication risk is very, very low, and the reherniation rate is 1%. So the surgery is outpatient. This patient will go home in an hour after their surgery. We're going to be done with their surgery in about probably 20, 30 minutes. We have 1 more disc to fix. We can fix up to 4 discs in a surgery. I prefer not to do 4 discs, but that we can do. This patient has 3 discs that need to be fixed. But we've had 4 before. It's not common, fortunately, because I don't like doing 4 discs, but I will do it if we have to. And one thing you'll find at Deuk Spine Institute is we'll treat what needs to be treated all in one surgery in your neck or back. We don't do necks and backs at the same time. Like if you have 2 problems, your back and your neck, we won't do both of them on the same day usually. We want to spread it out on 2 days because it's not really safe to do both of them on the same day. Not safe for the patient. Yeah. Why don't we take the next question?
Yes, next question is from Gail, and she said, I love these live broadcasts and follow whenever I can. I have another question. If a person has Facet syndrome, is the procedure different?
Yes. Hi, Gail. Thanks for asking and thanks for watching. Dr. Deuk Majan here. Yes, Facet syndrome is a completely different problem. So there's 2 types of joints in the spine. There are facet joints in the back, and there's discs in the front. This is a surgery for herniated disc, bulging disc, ruptured disc, degenerated disc. This is a surgery to fix a disc problem. If the patient's problem is not the disc, but the facets, we have facet joint treatments as well. The most common is called a radiofrequency ablation, or RFA. It's done with a generator of electricity that delivers heat to a probe tip and that probe tip deadens the pain nerve to the facet joints. It's called an RFA rhizotomy. There's other types of rhizotomies we do at Duke Spine as well. We just did one, as a matter of fact, right before this surgery. That patient had facet pain and facet syndrome. And we did a plasma rhizotomy, which is only found at Duke Spine Institute. It's basically a high energy rhizotomy that lasts longer than a typical RFA rhizotomy. As a matter of fact, we have a testimonial of one of our plasma rhizotomy patients. I don't know if you have that loaded up, but we just did it like a week ago, right?
Week ago, yes, and I apologize, I don't have it.
That's fine. We'll show it at another surgery in the future. This is bone spur right here, by the way. See how the laser just melts the bone spurs away? Lasers cut steel, you know, folks. I don't know if you guys realize that, but I hear all kinds of nonsense about lasers in medicine and how dangerous they are. They're no more dangerous than a scalpel. As a matter of fact, scalpel is far more dangerous. Laser, I can actually see what I'm doing on a microscopic scale. With a scalpel, you can't see. This is a big piece of herniation in the epidural space right here, what we're getting.
We do have another question.
Sure.
This comes from Alan on Facebook,
Yep.
and they asked, when you do surgery, do you often see that the discs are in a worse state than the MRI shows?
Oh yeah, great question, Alan. Yeah, the discs are a lot of times worse, much worse than the MRI. The MRI, there's a fresh herniation, by the way, Reiko. That's probably a recent one. You could see because it's fuzzy, looks like a cotton ball. It's not smooth. The older herniation fragments are smooth. Great question. I definitely find that herniations are worse when you get inside the disc with the endoscope. You can actually see everything better than an MRI. And remember, an MRI, it leaves out information because it only samples every 5 millimeters, and it does what's called volume averaging. Look it up. A lot of people don't know that. They think an MRI is like a snapshot, but it's not. It's actually a computer-generated image. It's kind of like, you know, when you watch those NASA pictures of the nebula, everyone thinks the nebulas are red and green and beautiful. They're not. They're invisible. You can't see them with your eyes. But what the artists do is they take those images, which are basically invisible radio waves, and they assign colors to them. So then they become, you know, colorful and beautiful. Just look up the Horsehead Nebula. You can see pictures of the Horsehead Nebula, but those aren't real pictures. They're just computer-generated images based on radiation densities, okay? Anyway, so an MRI works the same way. It basically excites, using a magnet, the water molecules, hydrogen ions within the tissue, and those ions then get unexcited, and as they get unexcited, they release their energy, and a detector detects that energy release, and depending on the type of tissue and its composition, you get different images from the MRI. So it's not a real picture. Whereas look at this, we're actually looking in the disc. We're seeing everything. These are herniations right here. So you can't substitute for true direct visualization, which is what we've got. Endoscope shows far more than an MRI does.
Scope on, please. Thank you.
So that's a piece of herniation. It's too big to come out. I'm just going to bivalve it, we call it. Cut it in half. Try to get it to come out. But you would never be able to get this out without the laser. It's impossible. So people talk about, oh, lasers, they're not necessary, they're dangerous. You read those articles, they're all written by surgeons who don't do laser surgery. They're just jealous, basically, of what we're doing. And they don't want their patients leaving them and going somewhere else. The real reason is, I'll be honest with you, Those articles are written by surgeons that are getting kickbacks for the implants they're putting in. Okay, all the metal plates and artificial discs that are put in, those surgeons are getting side money. They're getting paid handsomely to put them in, far more money than I get for this. So they're going to take a 90% pay cut doing this surgery, easily 90% pay cut, doing endoscopic surgery over fusions. So why do they want to lose their money? They don't. So basically the industry that manufactures plates and artificial discs, those companies are in bed with these surgeons that are writing the articles so that people don't come and have this surgery done, because they're going to lose that business. They're going to lose their money. They don't give a shit that the people have metal put in their neck, that it's bad for them. They just want their money. They're like a drug dealer. They're as bad as drug dealers, okay? The drug dealer doesn't give you heroin because it's good for you. They give you heroin because it's good for them. And, you know, they're getting money, a lot of money, and they're getting rich. So just as a drug dealer is no good for society, surgeons that do fusions are no good for society, okay? I'm making a bold statement because it's the truth. Now, was I a fusion surgeon before? Absolutely. I used to fuse all the time. I've done a lot of fusions, and I do really good fusions. But that's because people didn't want to pay for the laser surgery at the time, and now they do. And we're getting more insurance coverage, so more people are wanting it done. Okay? They don't want fusions. They're not stupid. People figure this stuff out, but they need someone to help guide them. There was a report just the other day about a spine surgeon who got $20 million a year because he was in charge of a big program where all the doctors were putting in metal implants, and he was making sure they were using that company's metal, and he was getting kickbacks. This happens all the time. I could tell you it happens everywhere. If you don't believe me, go to a spine meeting of neurosurgeons or orthopedic surgeons and look at what's called their disclosure of the speakers. The people that are teaching the surgeons how to do surgery have disclosures where they say, I'm a consultant for Medtronic, I'm a consultant for Deuk, I'm an advisor for Medtronic, I'm a researcher for Medtronic. Those are all ways of funneling money to surgeons to keep putting metal in people's necks. I've never been on the take, and I don't think it's ethical, I don't think it's right. And this surgery is so much better than any metal procedure of artificial disc or fusion that it wouldn't be right for me not to offer this to people. And that's what's happening everywhere else, is these surgeons are basically just taking money to put metal in people's necks and not telling the patients about this better surgery. So we had to stop that. That's why we run these surgeries live so you guys can watch. This is not some, Pixar animation fake surgery. This is real. That's literally the spinal cord right down there. I'm trying to get the pressure off of it right here. And this is another reason a pain management doctor can't do this. This is truly working right on the spine and the spinal cord. This is not a pain management type doctor procedure. This is a true surgeon, and not just any surgeon, a highly, highly trained surgeon. So that's why you're not seeing these procedures done in a lot of other places, is because the surgeons are not motivated financially to do them. They're actually going to get hurt financially. But, in medicine, you're supposed to do what's best for the patient, not what's best for your pocketbook as a surgeon. So that's why we do these procedures, because it's best for the patient. All right, we're pretty much done. That's the foramen on the right. That may be a little bit of herniation right there. I'm going to get it out. That's just in the armpit of the nerve root. Pretty much done here. Yeah, done. Good. Looks good. I want to swing back one more time and just look underneath this tube. Look at the blast marks on the tube there, Luis. You guys see all that in black? That's all the laser melting the steel. It's a pretty big herniation. just outside the tube, and I'm going to get it before we get out of here. I don't know if I think, come on, have that ready. I don't know if I got it. I think I shoved the tube back down and pushed it away. So let's go back and look. Where is it? It's right there. That thing is a monster. I don't know that I can grab it out. It looks too big. I'm going to have to bivalve it. Let me try one more time to grab it. It's just too big. Nope, going to have to break it into pieces. Again, you can see how traditional surgical instruments just fail to do the job right. You have to have the laser. So this whole business about laser, not useful, I'm telling you, it's just propaganda from people who don't have a laser and don't know how to use it. And in the end, they're just lying, but the lies will catch up to them. All right, any more questions?
I believe Gail asked a question on her follow-up from the Facet syndrome.
Sure.
She asked typical symptoms of Facet syndrome. Thanks very much.
Typical symptoms of facet joint pain is pain in the neck on the sides with rotation. So looking side to side, looking up and down, or looking up, sorry. So rotation and extension. Cannot get it. So looking up and particularly twisting your head side to side. You'll have severe pain on the side that you twist towards. That's the symptom of facet joint. And then you want to confirm the diagnosis with something called a medial branch block. A diagnostic medial branch block where the doctor, usually an interventional pain management doctor, will numb up the facet joints and see if it takes your pain away temporarily. So that is the diagnostic procedure of choice. Diagnostic MBB, medial branch block. Pretty standard, very commonly done. Oh, please don't. Yeah, we're trying to keep the tube in a position and reach down and grab this thing. But if I have to fiddle-faddle with it, I just can't seem to grab it. So we're going to have to go back to breaking it up. Good questions, though, Gail. All right, what other questions do we have?
No current questions.
Let's go ahead and show our audience a comparison of DLDR versus fusion.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
All right, welcome back. We've just completed the Deuk laser disc repair at C5-6. We've already done C4-5 shot. I've got to be able to see, guys. Shot. All right. Let's, I need to see better. Come on, Jordan, you got to figure this out, okay? I shouldn't have to tell you. Can you see the back of the disc? No. All right, good. We're going to move up 2 discs to C3-4. That'll be our last disc. Everybody ready? Shot. It's going to hold pressure for a minute, and then we're going to move. We're going to need some inline traction. We're going to need a little shoulder pull. And we're going to need, I don't need the coker. Luis, I may need you to do a little shoulder pull, okay? All right, so here we go. Everyone set? Shot? Good. So we're going to come out of this disc space. I don't need the coker. Shot? Not right now. And I'll tell you when I need it. Shot? Shot? All right, so let's get an AP. So quick AP. Right now, shot. Perfect, lateral. So we're in the midline still. Who set up the field, you or Oscar? All right. So we're gonna head up one more disc. Shot, everybody doing their job. Let's get another AP. I don't want this here, I want it there. Shot. All right, a little off to the side. Shot. That's perfect. Lateral. That's my lateral. I'll lose the tubes. Shot. Shot. It's looking good. AP. This is the hardest part for me. I just need peace and quiet and to be able to focus and not worry. 2, 3, 4. Everybody agree? 3, 4. Yeah, we're off to the side. Shot. So it looks like we're a little scoliotic. Shot. That looks midline. Lateral. I just need to get in the right over the front of the disc. We're in the middle, but I don't know that we're over the front of the disc anymore. We are. Mallet. Shot. All right, so let's just verify AP. Everyone hold it together for another minute. 2, 3, 4. Everyone agree 3, 4. That looks good. Lateral. So we can do a discogram on this one. Shot. Shot. Take it, take it. Shot. Shot. All right. Any more questions?
No
Any-
current questions.
Sean? Oh yeah, we're not gonna see it. All right, I think we got some out. Sean? This is our last disc. Sean? Sean? That looks pretty good. Just wants to pop out. Shot? Yeah, it wants to back out, so I gotta hold it. So this disc is actually pretty inflamed because there's a lot of pressure, shot, that's kind of pushing this dilator out. Shot? Huh? Yeah, it's not a collapsed disc per se, it's a high pressure disc basically. Shot? It literally wants to push out my instruments. Shot? Shot? So as we go in, I have a feeling the dilator is going to want to come out. Shot? 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 These are the hardest part of the surgery. Once you get the tube in and you're set, you're good. Shot? That's it? All right. Once we get that end of the tube docked at the back of the disc, which is pretty much where we are now. Yep, perfect. Love it. Take it. So we're right at the back of the disc, and we're right up against the herniation.
What was her most sensitive disc? Based on how much anesthesia I think it was.
Why do you say that? Huh. So a pain response. Interesting. Oh yeah, this of all the, I need that camera. I mean, I need the screen. Of all the discs, to me, this one looks like it's the most recent. Yeah, herniation. You know, the other ones look older. Pedal, huh?
You won't see the calcified spicules that you see.
Yeah. Oh, we're gonna see some here, but we're not gonna see as much. Look, this disc could be 5 years herniated. The other ones are 10, 20 years herniated. Grab her. What appears to be a softer herniation here. There's some calcium there. It's definitely not as bad as the last one we just did at C5-6. There's the posterior limits of the vertebral body. This is herniation. See, that's a piece of herniation right there. And it's sitting in the epidural space right here. There's some older stuff right there. You see it? Golden color. Just remember, gold is old. Okay? Gold is old.
So in med school we learned smoking causes increased risk of disc disease because of disc desiccation or drying out. Is that still hold true in recent literature? Smoking disc disease?
I have no idea. I don't think there's any correlation
I think you might.
between smoking and disc disease. We have a lot of non-smokers, and you know, you could always argue that maybe people with chronic pain are more anxious and they smoke to reduce their anxiety, right? Phew. A lot of herniation here. This is the worst one.
We have a question from
Sure.
YouTube. This comes from Reiko Pilot,
Okay.
and they ask, does the anterior hole in the disc you create during surgery simply heal the same way as the annular tear you are clearing?
That's correct. The anterior hole, but it's not a hole, right? Because we're not making a hole in the anterior part of the disc. We're simply dilating it. Dilating is not the same as making an excavation. Dilating means you put something in, it spreads the things open, and then you take it out and they go back to where they were. So we're not making a hole in the anterior part of the disc, we're just spreading it. So there's no repairing, but what little repairing there is done in the same way. Grabber. What's the issue, Luis?
They should know is this bag collecting water and it's almost overflow and it's found.
Why am I having, how's the irrigation? I'm sorry?
I just switched it.
Oh, okay.
Okay.
This is all nucleus pulposus. We were able to get the stain in this time so you guys could see the blue. And yeah, even though this herniation is newer than the other discs, it's still got some old areas in it. Old as in years old. And we did the comparison video, right?
Yes, we did.
Luis, is this grabber just doesn't feel very effective? Is it removing pieces?
I saw a couple in the last one. This one is a small one. Not much. Yeah. This is one right there, but it's not.
I just cannot tell. And maybe that the tube is just shifting a little bit, so, but just seems like, give me the grabber. It's just not getting out the pieces of herniation. There's a piece.
Yep.
But the teeth are fine. The teeth are fine. Fine. A lot of softer herniation on this disc, just as I had predicted. That's what we're seeing here. All this fluffy stuff. Again, you know, I can't even tell you how many pieces of herniation there are. They're uncountable. There's so many of them. And every time I go up, I float out another couple of pieces and back in. And there's more there. So this is a pretty badly herniated disc, C3-4. We don't get a lot of C3-4s. C3-4 is pretty rare to injure. The most common being 5-6, C5-6 that is, and in the cervical spine. And then the second most common is C6-7, and then C4-5, and then C3-4, that order. About 90% of the patients have a C5-6 herniation, the ones that we operate on. See the crack right there? You can see the annular tear. Okay, and the herniation is now stuck in there, and that's what we're removing. This is the annular debridement I talk about all the time. And look at those pieces of herniation coming out from where the spinal cord is, right there. That's a herniated fragment. Okay? So I'm going to go grab that out if I can. Of course, these pieces look larger in the endoscope because that's the job of the endoscope, is to make them look larger, so I could see them. But they're really only about 0.5 millimeter wide. There's the spinal cord down there in that crack. That's the back of the disc. Here's another piece of herniation right through here. All right, way to be prepared. Good job, Oscar. All right. Luis, you sweating? You're like me, you can't tolerate the heat, huh? Sometimes I feel like we're in the wrong state. Right?
We don't need an AC then.
Operating in the Alaskan wilderness. There we go. I like that. We have a vote for a Deuk spine in Alaska. All right, any other questions from our observers, watchers, followers?
No current questions.
All right, let's run, oh, there's another herniation that just came out. Let's run another video of what it is we're doing here, the animation. Endoscopic. Probably 5 minutes, doctor. 5 minutes. Yep, there's another bone spur.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. the laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. We're just wrapping this surgery up. And again, this patient had 3 herniated discs, C3-C4, 4-5, 5-6, and we are just finishing number 3-4. It's the last of the 3 we're doing. We've already treated the 4-5 and 5-6, and we probably have about 5 minutes left in the surgery. We've taken out of this disc at least 15 herniations, maybe 20 or 30. I lost track. But her her discs are pretty degenerated. Unfortunately, it's a condition where the inflammation has been going on for so long it destroys the discs. You won't hear that elsewhere because we discovered that at Deuk Spine. Degenerative disc disease comes from the annular tear and inflammation caused by the annular tear and the herniation. The longer it's there, the more degeneration you get. So the best way to prevent degenerative disc disease is basically to get your herniations fixed with the Deuk laser disc repair. Get rid of the source of inflammation and you get rid of the degeneration. It's probably, you're hearing this 20 minutes ahead of the rest of the world, or sorry, 20 years ahead of the rest of the world, I should say. It's amazing how slow progress is, but the reality is it's really hampered by, unfortunately, big industry financial interests who are just stuck on their golden goose, the goose that laid the golden egg for them, which are your fusions, artificial discs, anything metal they can put in you. They want to keep putting it in. Another herniation. We've had about 40 herniation fragments now in this disc, probably, if I had to guess. And they keep coming. Another one. Okay. I told my anesthesiologist about 5 minutes left. There's another herniation right there. We're going to be wrapping this up soon. If you have any more questions, feel free to ask me. Happy to take your questions. This would be a good time to type them up. If you haven't been to our website, go check out the Deuk Spine Institute website. We also have a free app you can download and use, Spine app on the Apple and the iPhone. Apple iPhone and the Android, I apologize. Just go to the App Store and type in Deuk Spine Institute. You'll see our app. And it's free. We also offer free MRI reviews to people that are in pain and want to know why and what could be done to help them. We don't charge. It's basically a virtual consultation. We do need your MRI. Can't do it without the MRI. So if you don't have an MRI, use a CAT scan. But basically we need something to look at. Any questions?
No current questions.
All right. Well, I think overall our surgery went really well. I think this disc was the least degenerated, but still degenerated. You can see all these bone spurs. They're not causing any problems, but I'm going to take down the ones I need to, which I've already done, and leave the rest because we're not here to do a bone spur surgery. That's not necessary.
Scope off, lights on, please.
I think I've operated on one big bone spur in my life to help a patient get rid of their symptoms, but bone spurs rarely cause problems. They see them all the time on the MRI report, and people freak out about them. A lot of surgeons don't even understand. They'll tell their patients they need the bone spur taken out when they don't. But the surgeons don't know any better. That's what they're told to do. Just a lot of misinformation out there, which is why we do these broadcasts, so people can get their questions answered and we can clear up and get to the truth. Truth is, back and neck pain is pretty straightforward. There's only a few things that cause it, and we can figure out what the cause is at Deuk Spine if we have your MRI and we do a visit. All right, I'm going to call our EBL 8 mil. I'm going to hold pressure for a minute, break this down. You can see actually it's pretty neat. Can you guys see over here?
Yep.
All right, check this out right here. Can you see this area?
Yes.
Can you see all the herniations that came out?
Uh-huh.
It's like a mining operation here. There's literally 60 little herniations here. And that's what they look like. That's how small they are. Look at that. They're probably a millimeter, half a millimeter, some of them. You know, they're just little boulders of herniation. That's what they look like. A lot of people think herniation is one big piece. It's not. It's many pieces. And if you've had a herniated disc for many years, you know that because every time you get a flare-up, that's another herniation. All right, well, there's the incision right there. We're pretty much done. Type your questions up. I'll come answer them for you. And we'll have another surgery for you in about an hour.
The last patient's coming in at 2.
Fine. I have a Ray Tech off the field. And let's go ahead and show our audience one of our patients that had this procedure. Maybe even do the comparison again between, fusion, ACDF fusion, versus Deuk laser disc repair. That would be a good video to run at the end. And type your questions up for me. I'll be happy to answer them. Good job, everybody.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged disc causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
I'm Dr. Deuk Majan here at the Deuk Spine Institute with one of my patients who's traveled from North Carolina because he had some herniated discs in his lower back and he was having problems with the back. What kind of problems brought you to Deuk Spine Institute?
Dr. Deuk, it was severe pain that I had never experienced before, and pain that scared me so much that I thought it was going to change the way I lived. I've got a family and I'm active, and it literally scared me to death. And as I'm talking to you right now, the hair standing up on my neck, the pain that I was suffering and where I thought I was, I didn't think there was going to be an answer.
And you were pretty much bedridden. You couldn't get out of bed. I remember you showed up here in a wheelchair because any standing was causing sciatic type pain in your leg.
Yeah, there was no doubt. And that's not an over exaggeration where I could maybe get up, like stand for 15, 20 seconds so I could get to the bathroom to go urinate, for instance. But then when I got there, I had to lay on the floor so I could rest up a little bit so I could stand with pain to even be able to try to urinate. And this went on for 2.5 weeks. It was absolutely brutal. And there was no respite. Pain that I had in the past, I could find some position where there was some respite from the pain, and there was nothing.
So your wife is a physician. Was she able to fix your back problem for you?
I wish. No, I mean, she consoled me. And in the town that we come from, we know a lot of folks. And to be absolutely honest, we just weren't getting a lot of help. And like I said, we know a lot of folks, and it was prolonged, and we were talking about pain management and all that, and that's just not for me. And like I said, I was scared to death.
The problem with pain management, unfortunately, is that it doesn't fix the issue when you have a herniated disc and back pain from a herniated disc, because you need surgery on that disc to repair it. That's what the Deuk laser disc repair did. And you can actually see here that we went into his disc with the endoscope and we were cleaning out the herniation with the laser. And the laser actually makes a huge difference. People say, oh, lasers, they're not used in spine surgery, but they are. And they're very, very powerful tools and very precise. So we were able to clean out your discs, remove the herniation. And how do you feel today?
I feel great. I mean, it's probably, I mean, I know I'm on camera right here, but I literally could not walk into the office yesterday. And I mean, you're gonna see my shorts and everything, you'll have to edit, whatever, but I'm able to walk.
That's awesome.
And I'm just, it wasn't even close. I was actually, and I don't know if you can tell from the camera that what my personality is, but I try to be very polite, and I was apologizing for profusely sweating because I hurt so bad. It's not because of the Florida heat by any means. It's because I hurt so bad. I'd never experienced pain like that. And like I said, there's no
because you're a redneck too. You know, you're not that far from Florida.
That's
you're
right.
Just up a state or two, right?
That's right. Yeah.
A couple of states. So you're feeling better today. It's been less than 24 hours since we did your surgery. You went home an hour after the surgery, back to your hotel with your lovely family who I met. And how do they feel about your progress?
They're happy that I'm happy. You know what I mean? Because they were scared too. You know, now they were putting on a strong front, but I am just telling you, I was at my wit's end. And I certainly are a lot more appreciative of people who have pain that I'm aware of, because when there's no rest from it, oh my gosh, you know what I mean? I was really at my wit's end, and you saved me. So I appreciate you very much.
You are welcome, sir. Is there anything else you want to say to your fans out there?
Thank you. Sorry, I could have prettied you up for you a little bit better. So just had surgery yesterday.
All right.
Cut me some slack.
Excellent. And you're heading back home today, correct?
Yeah, right. Going back on the plane later this evening. The kids are going to swim a little bit down here in Melbourne. I am just going to rest and watch TV, but then we're going to get on a plane a little bit.
Awesome. Yeah. All right. Well, congratulations. You had faith.
Yes.
Took the leap and you got the surgery done.
Yes, sir.
All right. Awesome.
Yeah.
It's Dr. Deuk at the Deuk Spine Institute here in Florida with one of my patients who had the Deuk laser disc repair for a back injury, and it was around 6 to 8 weeks ago. And you're back for a checkup. How you feeling today?
I feel wonderful. I feel great. I feel fantastic. I mean, this is the man. He's the man.
Well, thank
And I
you.
came in with a lot of pain, a lot of pain. I couldn't believe it, and now I'm virtually pain-free. It's unbelievable.
How long did you have your back pain? How did that start?
Oh God, that happened many years ago at work, at least 20 plus years. And I had other surgeries in the past, and they really didn't help. And this last one, it just got so bad that I had to do something. So luckily, through the grace of God, I came here, and
Amen.
yeah, and I'm A1 now.
Awesome. So you had your surgery, you've been doing therapy. Would you say the pain you had in your back before surgery is still there, or is it gone?
Oh, it's gone. It's gone. I have little twinges now, but they're muscular, and which is fine. That's going to go away over time. But my God, what a relief! I'm ready to get back out there and do all the things I used to do, man. It's kind of exciting. It's kind of fun.
Well, it's important that people understand too, when you have 20 years of chronic debilitating back pain, what happens is the muscles in your back shrivel up and atrophy because you're really not active anymore because it hurts too much. So, you know, we can fix the spine pain, but it's going to take time to rehabilitate the muscles and get them back to normal. So I'm glad we're touching on that. So what does your life look like now that we've gotten rid of your back and leg pain?
Well, yeah, I'm going to go back to what I've always done and what I've always enjoyed doing, which is my automotive hobby. And I'm really looking forward to being able to actually lift things again and getting the contorted angles that I used to get working under cars and stuff. It's just gonna be nice. Quality of life is it's
Not too soon with any of that lifting engines
all right,
and
all right,
contorting your
all
body.
right, yeah, all right. But I have, all kidding aside, I have noticed over the years I developed a way to walk, almost a crab walk kind of thing, and I got used to it, and I got, well, that's the way it's going to be. I don't have that now. I mean, it took a little while because it was some pain trying to get the muscles to come back. But my God, you just stick with it. If you got to get it done, stick with it, because you're going to get better. You're going to get better.
Well,
Yeah.
Congratulations. Is there anything you want to say to wrap things up to your audience?
He's the man. Come see this guy.
All right, congratulations.
Thank you, doctor.
You're
God
welcome,
bless.
sir. God bless you. All right, so now you've had the surgery. How are you doing today?
I feel awesome. I mean, the only pain is, surgery site pain, and that's
Okay.
it. No nerve pain.
So the pain that you had before the surgery is
Gone.
gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
I'm Dr. Deuk with the Deuk Spine Institute, and I'm here with one of my patients who just had the Deuk laser disc repair on her lower back, and she wants to share her story with you. Now, you came to Deuk Spine Institute because you were having back and left leg pain for how long?
Well, the terrible left leg pain, probably about 2 years, but prior, I've had issues since I was 14 years old. So it's been a lot of roller coaster pain since then.
So you've had back pain since you were 14. You're clearly not 14 anymore.
No.
And so that's like 15, 20 years, right?
Yeah, too long.
And so why didn't you get it fixed sooner?
Well, the doctors when I was younger didn't want to operate. They wanted to, I was young. They didn't want to take a chance because all the surgeries then at that point, there was just nothing there that wasn't going to be traumatic to my back and my spine. So I went through physical therapy, shots, decompression. They did that and nothing was really working. And then it eventually kind of got better, and then it would get worse and it would get better, and it was just up and down, up and down.
Up and down. And the reason it got better was the inflammation from the injury to your disc started to get better.
Yeah.
But then you'd have another herniation with activity, and then it made it worse. So
Yeah.
when we were in there, and you can see from this video right here that we were pulling out lots of big fragments of disc herniation. You probably over your lifetime from 14 until now had at least 10, 20 different episodes of herniation, and that's what we saw when we were inside there.
Mm-hmm.
All right, so now you've had the surgery. How are you doing today?
I feel awesome. I mean, the only pain is, you know, surgery site pain, and that's
Okay.
it. No nerve pain.
So the pain that you had before the surgery is
Gone.
gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
Now, you're not from Florida.
No, I'm from Ohio.
So you traveled from Ohio to the Deuk Spine Institute in Florida. Why did you come all the way down to Florida?
There was nobody near us or anywhere near us that had any other option besides either getting a discectomy or a laminectomy or a fusion. There was just nobody was doing anything else. And I knew I didn't want to do that again because I'd already had that done. So it didn't work. And
Didn't work.
I had a really amazing physical therapist that connected me with you, and the rest is history.
Yeah, your physical therapist found us and was intrigued with the surgeries we're doing here
Yeah.
and sent you here. So what are you going to tell your physical therapist? I call him Dr. Salinas. What are you going to tell him when you...
Oh man, I mean, I've already told him. I texted him the minute I got back to our Airbnb. I said, I feel amazing, and I can't wait to tell all the rest of the patients in our Facebook group, like, this works. So
It does. The Deuk laser disc repair really does work. Well, is there anything else you want to say to your fans out there or friends?
my fans and my friends, thank you for praying. Thank you for believing me. I think that's one of the biggest things. There's a stigma around back pain because you can't see it, that people are just faking it, or maybe they're babies. Like, why can't you just deal with the pain? And it overwhelms you. And so to come someplace that believes me and then fixes the problem, and now I'm sitting here and I can be like a fully active mom. So I'm just beyond thankful. Thank you.
Yeah, chronic pain robs people of their dignity and their happiness and joy in life, and also their loved ones, the people that care about them.
Yeah.
Because they suffer with you.
Yeah.
Yeah.
A lot.
Well, congratulations and praise God.
Yes.
You found us.
Thank you very much.
And I think you're going to do fantastic.
I'm looking forward to being strong again.
Awesome. All right. All right, I'm here with one of my patients who traveled from Australia to Florida to the Deuk Spine Institute for treatment. And you look happy today.
Yeah.
Yeah? Why are you so happy?
I'm happy because my back pain is gone.
Your back pain is
and
gone.
my leg pain is gone
Awesome.
from the disc. Yeah.
From the surgery yesterday.
Surgery yesterday. Yeah.
And you had the Deuk laser disc repair.
I had the Deuk laser disc repair. Yeah, that's right. Yeah.
So why did you come all the way to Florida from Australia for the Deuk laser disc repair?
I've been suffering from back pain and leg pain for nearly a year after an accident. So I did a lot of conservative treatment like physiotherapy, exercise physiology, but it hasn't cured my pain. The pain was chronic, and I've been suffering from a lot of issues, emotional frustrations and things, and sleepless nights. But a couple of neurosurgeons back in Australia has offered me a surgery. They both offered me a fusion, which I don't want to go for. So then I have looked into Dr. Deuk. I found Dr. Deuk, and he's doing an amazing job doing a laser technology and also doing very minimally invasive procedure. So I thought this is what I wanted, and it's a faster recovery. I could go back and work back within a couple of weeks. So that's why I traveled all the way from Australia to US.
Yeah, and we did your surgery just yesterday evening.
Yeah.
So it's around 12 hours now from the surgery, and your pain is gone. And you can see in the video here where we did the laser surgery, we got into your disc endoscopically, and we used the laser to clean the tear in the back of the disc at L5S1 where their pain was coming from all the inflammation. And now that back pain is gone. And you didn't have to have fusion. You didn't have to go to the hospital. You didn't have to deal with narcotics, right? You said you took a couple of anti-inflammatories and a muscle relaxer yesterday.
Yeah, but I didn't have much pain with the surgery because it's laparoscopic and minimally invasive, I believe.
Yeah, that's correct. That's correct. So there's not a lot of trauma. There's no scar tissue. There's just a little incision. And of course, we don't remove any bone or ligaments from the spine. It's all done minimally invasive and naturally. So it's a natural healing of the disc. Now, You said just a minute ago you were suffering with a lot of pain and the effects of pain on your psychological well-being. And I know what you do. You're a nurse who helps patients that have behavioral issues, you know, like anxiety, depression, and maybe other things. But you can appreciate how devastating chronic pain can be on people and their loved ones around them.
That's true. Yeah, I completely agree. It not only disturbs you, also your family. That's what I understood. So psychologically, after a few months, I should say, you will have that frustration of chronic pain, and then your behavior start changing towards others as well. And
Yes.
it's not really, you know, like about you. It's also about your people living around you. That's very important. Yeah.
You came here for a purpose. You got your surgery that you had hoped to do. Now you're going to go back to Australia.
Yeah.
You got a long trip ahead of you coming up. And how do you feel about your experience here at Deuk Spine overall?
Oh, it's really good. Staff is really welcoming, and you know, it's spot on, and they receive you with a smile, and which is really great. And my father was telling, oh, it's amazing how, you know, he never thought that in American health system, people like, you know, the clinicians are like this. So he was treated differently probably before while he lived in US, but it was really amazing, and your staff is really cool. I
Thank
should
you.
say, yeah, they're welcoming, they're good.
Thank you very much.
And you are the best, I should
I
say.
appreciate it. It's an honor to take care of you, and it makes me feel so satisfied to see you happy and out of that pain. So congratulations.
Thank you, doctor.
You're welcome.
Yeah. If you're suffering from back pain, this is you know, like a very good cutting edge technology and very advanced surgery, which Dr. Deuk has developed his own, and without minimal, you know, like no damage to the bone, no damage to other things, and easily approaching to the disc and removing it. He is very skillful in reaching there without, you know, manipulating any of your muscles or anything. And you can see from me that I have recovered within few hours after the surgery. So I would say if you don't want a long-term complications from the surgery, this is the best surgery you can get done by Dr. Deuk here.
Congratulations once
Thank you,
again.
doctor.
I'm Dr. Deuk, and hope you've enjoyed our broadcast so far. We've been broadcasting a surgery that we're doing today live at the Deuk Spine Institute from our operating rooms at the Surgery Center Vieira. And our patient had 3 herniated discs in her neck. You could see from that MRI that was posted during the surgery at the bottom corner, they're pretty big herniations. Now, when you see a dark herniation like that, usually it indicates an older type herniation that's been around. Gray color or white color and gray color indicate more water content. White being most water, gray being less water, and black being the least amount of water. And what we saw when we got in there was indeed that most of the herniation was old, and it was mostly a lot of scar tissue with calcium. And the calcium is also dark, so that also contributed to the darkness of the color of those disc herniations. Long story short, Deuk laser disc repair is the procedure you watched done today. It's endoscopic. It's done through the front of the neck. We go through the disc to the back, and I remove the herniations using a laser and grabbers. We also do what's called an annular debridement, which is the most important part of the surgery. Now, we have a question from one of our audience. Do you want to read that question for me so I can answer it?
Yes, sir. This comes from 777H Shar on YouTube. And they asked, so the tissue/disc can repair itself? I wish I had known. I had a C3-C4 fusion 10-20 by 20 herniation and spurring from an injury.
Okay, I believe it's 7778 Shar. Thank you for asking. I'm Dr. Deuk. Let me show you what's going on. All right, so let's take the disc and just look at it for a moment. When you get a herniated disc, we're going to take this red thing out, remove it, It's a cushion between two of the bones. We're going to look at it and kind of flip it up so you can see the back of the disc right here. What happens in a herniated disc is you first get a tear in the wall of the disc called the annulus fibrosus. That's really a strong, strong wall. It holds this hydraulic jelly called the nucleus in position. When you get that tear, it allows the jelly then to get pushed out through the tear, because now the wall is compromised, it's broken, and the jelly can push through the wall and get embedded inside the wall, and that's what you see right here. So you have some of the jelly stuck in the wall, and you have some of the jelly sticking out. That's the herniation. This is herniation, and this is herniation. Both of them are herniation. This is called interposed herniation. This is called extruded herniation. The point is, with the Deuk laser disc repair, we go in, we use a laser to zap away all the herniation, and it leaves basically a small defect, which will then seal out over. It takes about 12 months to fully heal. But yes, we can definitely repair discs now. Unfortunately, surgeons don't tell the patients about it because they want to do fusion. Fusions involve putting things like metal plates and cages into your spine. Why do they want to do this? Because it pays a lot more than laser surgery that I just did. And the companies that sell these plates, how much do you think that piece of metal is worth? If you were to go to Home Depot and buy that, it'd probably cost you, what, 10 bucks maybe? Okay. Bunch of screws, 6 screws and a metal plate. Probably 10, 15 bucks to make. Well, when you make it for the spine, you get to charge $1,000 and get paid $1,000 bucks. Plus the screws are about 100 bucks each. So you add it all up, you're looking at about $1,600. Now that's just for the plate and screws, $1,600. There's a cage right there you can't really see. It's a spacer, and there's 2 of them, 1 for each disc. That cage is another 500 to 1,000 bucks. So by the time all said and done, that's $2,600 that's going to a company that manufactures those things for probably under 20 bucks, right? So think about the profit margins. Now these companies have been selling these products for 30, 40 years, okay? And whether it's an artificial disc or it's a cage and a plate, they manufacture them. And they make billions of dollars in profit a year. Now, they're not stupid. What they do is they go hang out with the surgeons. And they say to the surgeons that are busy, there's an old saying, 10% of the spine surgeons do 90% of the surgery. I don't know if you heard that, but it's absolutely true. 10% of spine surgeons do 90% of the surgeries. They go find those 10%. They already know who they're going to be. They literally groom them from residency, and they become their friend. They say to them, hey, if you put metal in for us, you can be a speaker for us and go to meetings and be a talker. You can have, special consideration, and in the end you're going to make millions of dollars extra putting our metal in people. So you people out there are going to those surgeons that are basically getting rewarded for putting metal in your spine, and you think they're going to tell you about endoscopic surgery that doesn't put metal? Hell no, they're going to lose money. So they're not telling you about these surgeries, which really bothers me, because a doctor has a responsibility to do what's right for the patient first and foremost. It's called the Hippocratic Oath, and it makes me sick to see this stuff happening. And the people that it's happening with is pretty much everybody in the field. So I've lost confidence in my colleagues, to be honest with you. They're just a bunch of money-hungry, grubbing people. Now, do we charge for surgery? Absolutely we charge. We can't run a business without revenue, so we have to be paid. But at the same time, we're not putting metal in your neck that you don't need in there. So I'm sorry you had the fusion done. The bright side of it is that, you only had 1 disc fused. You could have had, like some of these people, 6 discs fused, or metal going up and down your whole spine. I've seen it. It's disgusting. I had a patient yesterday in clinic. She had literally 20 screws in her back, from her thoracic down to her tailbone. I'm like, why the heck would anyone do this much fusing and metal? There's really no reason for it. She only needed about 6 screws because she had a traumatic injury to her spine, but the surgeon went in there and just put extra screws to make more money. You guys got to know about this. That's why I talk about it. All right, any other questions?
That is it.
Well, I hope you enjoyed the broadcast. We'll be back for another Deuk laser disc repair, anterior cervical. This patient comes to us from Vancouver, Canada, all the way here to Orlando, Florida, where Deuk Spine Institute is located on the Space Coast, over by SpaceX and NASA. Anyway, he came down here to have endoscopic surgery done. He did not want fusion done. He did not want metal put in his neck. He wanted his disc repaired the right way, so we'll be doing his surgery next.